Hello, everyone. Thanks for coming tonight. What a beautiful setting. And so tonight we're talking about the chronic disease management universe, which there's lots of constellations and lots of galaxies. So we'll get on to that. First of all, our acknowledgement to country. So I'd like to acknowledge the Ngunnawal and the Ngambri people, who are the traditional custodians of the Canberra area on which we meet today, and pay my respects to their elders past, present and emerging. And I extend that to all Aboriginal and Torres Strait Islander peoples here today. So first of all, we're very lucky to have Kylie Gibson with us. She is the business manager at Fisher Family Practice, and she wrote a very funny kind of blurb or précis about herself, which I'm going to read. So she describes herself as an accidental practice manager. She's got a background in psychology, training and clinical trials. And she was asked to help her husband, who's the practice principal, Martin, out for 6 months in 2011. And since that time, she discovered that she actually really liked being a practice manager and has stayed on. And she sees her role as a trainer and supporter, a bit like a cheerleader, to very well-educated and a very supportive team, rather than a micromanager. So she trusts her people, and she enjoys thinking about the practice at a population level and uses data mining skills to help her teams meet their goals. Her life motto is, "I haven't failed. I've just found 10,000 ways that didn't work." So, and she thinks about problems as things that you have to keep on chipping away at. So baby steps, but it's all progress, and the continuous process of change and improvement. And she's the business manager of 3 places. So Fisher Family Practice, Holder Family Practice, and Fisher Allied Health. So welcome, Kylie. Thank you for being here. And I'm Dr. Leonie Harcourt. So I am the GP advisor at Capital Health Network, and also I'm a GP 4 days a week at Watson General Practice. And I've been working in general practice since 2008. And I have to admit that I am not kind of, 100% expert in GP management, plan, team care arrangements, chronic disease management. And I do find sometimes the language quite bamboozling, and the billing items bamboozling, and the time and the recalls and the follow-ups and all that. So it was very much appreciated this opportunity to talk to you about it and to share my experience and to learn from all of you. So if there is anything in my talk that's incorrect or that you would like clarified, please say something, because it's better to get it right than to just keep going on the same path. So thank you all for coming. Okay, so as I said, the chronic disease management universe. So there's multiple galaxies, as you all know. So there's a GP management plan team care arrangement galaxy, which is the items 721, 723, 732, and 10997. Then there's the DVA galaxy, the aged care, the nursing home galaxy, health assessments, cycles of care, medicines review, and the mental health item numbers. But the good news today is that we're just going to cover one galaxy, which is the GP management plan team care arrangement. So just a flag for health pathways, which I'm not sure all of you are aware of. There's little kind of bookmarks up there. So that's each of the area health networks has a health pathways, and they're really useful. I look at them every day. They're really good for kind of finding out what to do or what resources are available or how to refer things on the correct template so that it will go through. So yeah, don't forget health pathways. They're very helpful in chronic disease management. So everyone loves statistics. Yeah, yes. So in Australia, there were 27 million people last year, and about 46.6% of Australians had at least one chronic condition. So I'll come back to the definition of chronic conditions, but that's a lot. And then 56% of men and 49% of women over the age of 18 had one or more chronic conditions. And about 19% of Australia had 2 chronic conditions. So there's a lot of GP management plan team care arrangements we can do for all these people. So what is a chronic condition? The MBS is quite loose in its definition of what a chronic condition is, but you have to have a chronic condition to be eligible for a GP management plan, team care arrangement. So the MBS defines a chronic condition as a long-term or terminal illness which has been present or likely to be present for at least 6 months and includes and is not limited to asthma and COPD, cancer, cardiovascular illness, diabetes, musculoskeletal conditions, and stroke. So there's a little thing from the Australian Institute of Health and Welfare, just kind of, it's from 2011, but showing about how chronic conditions are divided up amongst the Australian population. And you can see that cancer kind of unfortunately takes up a big share of it. But then again, other does as well. And so we all can think of multiple examples of what other might be. So there's no real exhaustive list of what is a chronic condition, and it's really up to the discretion of the doctor and up to definition. So there is a lot of flexibility in it. So to be a chronic condition, they say it has to occur across the life cycle, so younger, older people, and be complex and require complex and recurrent care. So not just the one-off care or 2 appointments, but something that needs long-term. You've also got to think about it in terms of the framework of, does it impact on quality of life and create disability or limitations? And may it occur, precipitate a gradual deterioration of health? So most are not life-threatening, but often they can cause premature morbidity and mortality. Okay, so I just thought we could do a show of hands. So like maybe people could put up their hands if they think it's a chronic condition or not a chronic condition. So celiac. So chronic condition. Yep. So yeah, that would be one that would qualify. How about long COVID? I think now it would be. So most people, long COVID is after 3 months of symptoms, and unfortunately people don't seem to be kind of recovering very quickly. So often it is taking more than 6 months to recover. So that would be a yes. How about obesity? Yep. So obesity is considered to be a chronic condition and or the sequelae of obesity. What about gestational diabetes? Yes, yeah, so it's not considered a chronic condition, and the MBS specifically says, yeah, gestational diabetes is not a chronic condition. So why are we doing this? So how can it improve patient care and potentially practice income? And that's why we're doing it, to improve patient care and potentially practice income. So normally, as you know, GP and nurse consultations are like ad hoc problems, solving for individual issues. And there's all these time pressures and juggling multiple other conditions, and you'd never really feel like you do a thorough or comprehensive job. So there's a lot of band-aid solutioning and putting out spot fires. So the GP MPs and the TCAs, they offer the opportunity to pause, to see the patient as a whole person with complex, long-term interdependent needs. It gives the care team time to create a coordinated plan to enhance the patient's health and well-being rather than the fingers crossed approach that she'll be right, mate, hopefully. And it provides the reviews of the GP, MP, TCAs, provide a space for the patient and the care team to reflect on the progress of the goals and the problems and the actions to see if they're stable, if they're deteriorating, if they're improving, and if the approach needs to be modified. So then talking about, let me just see where we're at. Okay, so the other thing is that they're very useful for patients who have problems paying the gap fee, so socioeconomic disadvantage. And unfortunately, most of the chronic disease disproportionately does affect people with lower incomes. So this graph here, I'm not sure if it's clear for you, but essentially it shows that the poorest 20% of Australians are twice as likely to have 2 or more conditions compared to the wealthiest 20%. So that means they're going to be seeing the doctor more, and unless there's some way that they can, an affordable way they can see the doctor more, they're going to be out of pocket for a lot, and they're the people who really can't afford to be out of pocket. So there is a bit of a social justice aspect to this. So what it is, it's encouraging holistic care. So holistic care in the terms of looking at the whole patient, and also being comprehensive and caring. So it creates improved trust and relationships between patients and their healthcare team. The forward planning of the GP management plans rather than the retrospective or ad hoc planning and regular reviews creates accountability and compliance. You have real life monitoring of progress and outcomes, and better compliance with treatment regimes. So all in all, you know, a very positive activity to do for your patients. So there's some really great kind of websites and links and PowerPoints online, and we're going to make all these slides available to you. But there was a great PowerPoint chronic disease management plan for practice nurses and practice managers from the RACGP. So I just kind of plagiarised their clever work. So there's talking about how GP management plans enable ongoing review of patients, improve patient health outcomes, as I said before, checking that all tasks in the care plan are being actioned and all care team members are doing what's in the plan, and making sure they're current and up to date, so they're not reflecting kind of 2 years ago's problems or issues. And also make sure that, you know, things like HbA1cs are up to date, cholesterol levels are up to date in diabetes, spirometry, in asthma and COPD. And also the patient feels that you're listening to them, so they have an enhanced sense of being cared for by your practice, which, you know, everyone knows that means that you're going to get better outcomes and the patients are going to be happier, and that's really very important. But they do require a very good system to kind of be implemented successfully. So rather than an ad hoc manner, and Kylie, fortunately, is going to talk about that. And so another great website for looking at chronic disease management plans is the Nepean and Blue Mountains PHN, and they were also looking at it in terms of hospitalizations and presentations to emergency departments. So they found that 48% of potentially avoidable hospitalizations in their area were for people with chronic diseases that could have been managed by their GP in the GP scenario. So it's about taking a bit of the pressure off the emergency department. So the other thing is that, as I said at the beginning, 46.6% of Australians have a chronic disease and about 19% have 2 chronic diseases, but only 16% of Australians had a chronic disease management plan in 2021. So as I said, there's kind of room for movement there, and I'm sure we all can think of patients that could benefit from the GP management plan team care arrangements. And interesting with the team care arrangements, only about 9.2% of people last year took up all 5 allied health services. So there's also kind of a lot of capacity for extra care that hasn't been used. When they broke it down into what kind of illnesses use their allied health services, diabetes and osteoporosis used it the most, and then everyone else didn't use it that much. So that's my talk. Another flag for the health pathways. I found this one really useful. It's an allied health directory. So if you want to look up who's a podiatrist, who's a child physio, you know, who's an OT doing this website here, if you can link onto it, the Allied Health Directory's Community Health Pathways, ACT New South Wales, is really great. It's got public and private referrals and also referral templates. Okay. Thank you. Any questions? Okay, Kylie.
Okay, so it's great. Chronic disease management, everyone knows the concepts, everyone's familiar with it. Even if you're just new to general practice, you've probably heard of the concept. And so I'm just going to talk a bit about what sort of things we need. So hands up first, who's a practice manager? I always love to know who I'm talking to. 1, 2, 3, 4, 5, 6, and 6, yep. And everyone else practice nurses? Yes. And I see a GP snuck in here. Melian, Deary, yes. Any other GPs? Another GP? Great. Okay, so I just like to know who I'm speaking to. So I'm obviously a practice manager. I'm not a practice nurse and I'm not a GP, but I have been an accidental practice manager for quite some time now. So I think I've got some experience in it. So what is this? Does anyone know why I've done this? Has anyone heard of the concept of pie in the sky? Yeah, I'm a pie in the sky thinker, and that's how I run my practices. So I like to think not just with chronic disease management, but everything. I like to think, what is our pie in the sky? So pie in the sky is, the definition of it is lofty but somewhat unrealistic goals. So, and I think we should all have those as working in general practice, because we are all aiming for the gold standard of care, the gold standard of diabetes management, the gold standard of this, the gold standard of that. There's reams and reams of paper all about the gold standards. So I find all those very boring. I prefer to picture it as a lovely pie in the sky. So I can't come here and say this is exactly what each practice should do. If I came and did a secondment at your practice, your pie would look different, taste different, have a completely, it might have cherries, it might have meat, it could have something completely different to what my pie looks like. So, but everyone should aim for that pie in the sky thinking. And when we're talking about chronic disease management, part of that pie in the sky thinking comes from thinking about planned versus acute care. So can I have a show of hands how many people felt like we were in very reactive medicine for the last few years? I think we were all in very reactive. The COVID forced us into that really reactive, like not a single plan apart from, are you eligible for your third shot or not? I don't know, that's a plan. So like everybody who is a practice nurse, practice manager, and GPs, we're all thinking on our feet, thinking about COVID vaccinations in and out, and chronic disease management largely got put onto the back burner. But gradually, as a practice, in my own practice, we are starting to think about our pie again and what our pie looks like, and getting that thinking back again. It's been hard, I have to say. We've been 2 years of firefighting, but now it's time to start thinking about what our gold standards are. So first steps, what are your first steps? Aside from thinking about planned versus acute care, does anyone get the differences between those? I like to think of it planned versus acute. The planned is like, what is the patient expecting when they leave the consulting room from whoever's seeing? What are they expecting when they leave the reception desk? Do they know what's coming next with regard to their chronic disease? And does your team know how to talk about that? So reactive is what we've all been doing, or that acute presentations of ERTs and coughs and colds and all those things, the gastros and all the lovely things that we see day and day. So that's my definition of planned versus acute. Understanding how to do all this, of course, starts with the MBS. Who loves reading the MBS? Come on, show me your hands. Don't you love reading? Yes. Oh, thank you. I have a sister in the back here. I actually like reading the MBS. It's very convoluted and everything, but I think it's really important to know what the MBS comprises of and know what the fact sheets and your descriptors. I have put just a couple of links up there, but there's a wealth of knowledge about it. It's sometimes you read it and then you say to your colleague, can you read that too? And they go, I don't know what that means. And I go, I don't know either. And so you Google something else. So, but there's Facebook groups and all sorts of things to help you to work out what the MBS is actually on about. So, but do take the time to read it. Okay, who is this person here? So we've got 23, 36, 3, 23, 23, 23, 23, 3, and a 93624. Do we have any idea who that person is? No. Do you think Medicare has any idea who that person is? They've got some other information, obviously. They've got the demographics of that person. But that's a typical person that often comes through our practice. Like if I looked at the billing history of a lot of our patients, they have a billing history that looks pretty much like this. Does this mean that our hardworking GPs aren't doing the jobs of chronic disease management? Of course not. Of course they're doing the hard work of chronic disease management. But does the anatomy, the MBS anatomy of that patient reflect that? Not at all. Often. And don't get me wrong, I'm not standing here saying that our practice is any better than anyone else's practice in this room, because everyone does this. And there's lots of reasons why we do this. So here, this is a billing anatomy that might look a little bit better. So it might be this lovely lady. I always use Mary Jones. I apologise to Mary Jones, wherever she is, because I talk about her a lot when I do talks, but she's not a real person. That's just my go-to name. So 721, and then a delay to get the 723 back, because obviously we have to wait for the allied health professionals to agree to come on the plan. But then part of the plan might say that that patient's due for immunisation for their whatever flu vaccination, and the doctor has written in that plan that part of the practice nurse's scope of practice is to do an immunisation. So, and in that time, you can use the opportunity to talk about their chronic disease. So, and then you can build a 10997 as well. So they come back for their reviews. You might be reviewing the GP management plan. You might be reviewing the team care arrangement as well. The practice nurse is helping to assist to make sure that all the documentation is back and all these things. The patient might be over 75 and you can have a 707 done as well. Then we've got another review and then a 23 because she gets a cold and comes into the practice. So another 3, another 10997. Then she gets her COVID vaccinations. Do you think that that's a more accurate MBS anatomy if we're billing our pie in the sky type billing? Yeah, it is. But does this happen very often? No. But does that mean we shouldn't aim for the pie in the sky? No, we should absolutely keep aiming for that pie in the sky, because it's really rude, but I call them the well-trained patient, the patient that comes in that has the expectation, that the doctors are really clear on the expectation. They like that framework to work within. They like knowing, they say, oh no, I'm going to see Dr. Martin in 2 months' time regarding my diabetes management. But then they know that if and they know they'll probably get bulk billed for that consultation, so it's not a financial impost, but they also know if I'm sick and I need to come for my cough, cold or whatever, then I'll come to the doctors when I'm sick. So they're not trying to cram their laundry list of consultations into that one thing that the doctor's trying to do. The doctor's then not forced into that reactive style of medicine. So, and then our billing anatomy becomes more like this. So of the practice nurses, who likes looking at the past billing history? Yeah, great. That's absolutely fantastic, because I think it's got lots of very useful information. So use the health summary of a patient. So everyone might land on the health summary. You can set your software, everyone uses different software, but that health summary screen, I love the health summary screen because it gives a snapshot of where everybody's up to. That and the MBS item numbers that are billed, you can know pretty much straight away who's coming into your room before you look at their name, before you look at what they've done in their last progress, before anything. So I would encourage everybody to get familiar with looking at that information if you're not already, and then thinking about, okay, like I can see that Mary Jones did have a chronic disease management plan done 3 years ago, but then COVID hit and she hasn't come back again. So maybe because she's here getting her ears syringed, we can have a chat about that, because that's an opportunity to have a talk and then have a chat with the doctor. So it's all about looking for opportunities and helping the patients to get back into that thinking themselves, because we're not just educating you, you're educating the patients in turn of getting into that planned care themselves. So they're going, all right, what am I expecting when I leave this consultation versus the reactive type medicine? So if you can do anything, what steps, baby steps, can you take to make the MBS picture clearer? I always say to my doctors, like, try and get that reflecting the care that you're doing. None of this is a criticism of any of the care that GPs are doing, because GPs are busy, wonderful, amazing, giving humans, but sometimes their MBS billings don't reflect the care they're doing. That means their income can sometimes go down, the out-of-pocket costs to patients can sometimes go up, and our pies in the sky look a bit like mincemeat on the floor. So, okay. Do you have what you need? So I really think that a lot of this stuff so when I came into, just in my past, I came from clinical trials. So if you work in clinical trials, it's really, really structured. Every single question that I answered, I would say, could you refer to the protocol about that? And the protocol was like this fat, and every single possible permutation was done. All the endpoints were really clearly defined. There was no opportunity to be reactive or wiggly, because that's just wasn't able to happen in clinical trials. So when I came along as being an accidental practice manager, I thought, how can I bring some of that clinical trials thinking to general practice? So, and I think some of the basic things, what do you need? You need time, you need templates, you need technology, you need teamwork, and you need trust. So all of those things are really important. So time. So if your day is back to back full of COVID immunisations, are you going to have heaps of time to do chronic disease management? Of course not. Like, it's just unrealistic to think that any of that can happen. So talking to your team about getting some time back in your day to work out how you can do this, like how you can do your gold standard with just one patient for a start. Like, think about Mary Jones as your gold standard patient. How can what time do I need to do this to get Mary Jones through our system as such? And then think, okay, what can I do with 2 patients, then 3 patients, then 4 patients? How much time do I need as a practice nurse or a practice manager to help facilitate this? And how much time does the GPs need to in order to fit this into their books? So, because there is some hard barriers coming up. Now, in my practice, templates was a real problem. We use Medical Director. It's about like using the abacus of computer word processing. So, and it was a fundamental barrier to our doctors doing care planning because they hated it. They're not very good typists, bless all the GP's heart. Some of them are really, like my husband, for example, watching him, and Louise is a practice nurse that used to work for us. You've seen Martin type, haven't you? It is the most painful thing, whereas Louise types like the wind. So we had to have effective templates, and I spent so long getting the templates working better for our practice. And that was something that I just said as a quality improvement goal for ourselves, because that was a fundamental barrier to care planning. It was something as basic as the templates. So look at your infrastructure. Is it working for you? Or is there things that are just plain clunks? So with that is technology. So we've got, do most of you use something like Smart Recalls, Hot Docs or AutoMed or something like that? So are you using your technology to support the infrastructure that you've put in place? So sometimes the doctors aren't putting the recalls on. So, and if you don't put a recall on, then blessed Hot Docs can't do a thing because there's no recall there to action. So what kind of things are you putting in to put those steps in to let the infrastructure of your practice do the work for you? Automated infrastructure I'm talking about. If you don't have automated infrastructure, you'll need more people to be able to help. So that goes on to teamwork. Who is involved in your chronic disease management programs? Everyone is involved to some degree. We've had receptionists helping with it because they've got an interest in it. I've obviously got an interest in it. Practice nurses have got an interest in it. Doctors have got an interest in it. And we put up graphs and we'd do cheerleading and all this sort of thing to try and get our numbers going, because we were a really bad practice for chronic disease management in terms of, not that we were doing a bad job of caring for our practice, our anatomy of the MBS was really bad for Mary Jones. So we put some things in, and I just purely did graphs on the wall. Do you remember those graphs, Louise, on the wall, showing how the infrastructure that I put in through templates and talking about it led to gradual change, And then I didn't have to cheerlead anymore because I'd made it easy for the practice to do it. Trust is another thing. So one thing that I've noticed in our practice is because we made the template so good, sometimes they circumnavigate the nurses. They just go, oh, I'll just smash out the GP management plan myself. We really need to get a position of trust and help and understand that the nurses too are contributing a lot and they want to form relationships with their patients. I know from experience of working with nurses over many years and from being a practice manager myself, that nurses and practice managers often feel very isolated in their roles. So because the GPs are all busy with their patients and you're doing immunisations, but we're trying to get that position of trust and get everyone back working in a coordinated way towards the same goals, that pie in the sky thinking. So if everyone can take away just some ideas, don't let me talk too long, by the way. If everyone can take away some ideas about what are your barriers? Like, can everyone think of some barriers in your practice for chronic disease management? So once you've got your pie, obviously there is other things. If I did our gold standard of chronic disease management, no patients would be able to ever get in with Anne-Marie ever, ever, ever. Because these things take time. If I fill her books up with 707s and GP management plans to the eyeballs, to the gold standard, then patients simply won't get in. So you really need to be careful of what you're doing because it has to be scalable to a degree. And you have to understand that not all GPs work the same, not all practices work the same. There's some fundamental differences. But for us, like we don't get through anywhere near enough 707s, like age health assessments is what we would like. There's not even close to getting through as many as what we can. And for our chronic disease management patients, I was looking at your figures, Leonie, and I was thinking about that, how that reflects to our own practice population. And it is way, way underdone, but we're often booked out a lot in our practice. So it's a balancing act too, and making sure you have enough time. So if you are chucking in lots of chronic disease management, you have to make sure you protect enough time for the acute management as well, because you can't artificially, or not artificially, but you can't just blow your books out so people can't get into you when they've got the things that they really need to see you on the day. Okay, so chronic disease management takes time. Oh, I've probably already talked about all these things without even changing my screen. Sorry about that. Look at my very happy clocks. So one of the things that does save time is your data mining tools. So does everyone love PenCat? Some people love it, some people hate it. Honestly, I always used to say, if we were doing chronic disease management like we used to, like Alan Albanese, you would get awesome care, but Zachariah Zedarai would get none. Because everyone in our thinking, we all start at the A's and we try and work our way down the list. I feel sorry for anyone with a name that's got G and later for a surname. So that's where data mining tools comes in, because data mining tools enables you to work at a population level. So because you are pulling those numbers at a population level. So you can't possibly do it any other way. So if you're not using data mining tools and if you don't love it, that's perfectly fine. But someone in your practice probably does. So that's where you can use your team's strength. So I know I've got another admin person on my team. She loves chronic disease management. And if I just go, here, can you do some, oh, she's off like the wind. She finds it really fun and interesting. So, and then that helps. So we have a new practice nurse and she's learning the roles of data mining and all these things. And it takes time. It takes time and confidence. But one thing I can say with PenCat, and all the stuff, there's umpteen recipes. There is a million recipes about how to make your pie in the first place. There's lots and lots of support on the Capital Health Network's pages with your quick cycles. All of it's to do with your quality improvement and all these things. And you can't break it. Like you can run all the things for PenCat in the world, all the random searches you like, and you will never break the database. So that's to go nuts. Ask yourself, like think, what does my pie look like and how can I answer this question? And absolutely go nuts with your data mining tools. So, and if you don't like going nuts with your data mining tools and you don't have someone, then ask your team, who would like to learn this? It doesn't have to be a nurse. It doesn't have to be a practice manager. There can be other people in your team that can do this. Am I talking too long? No. Okay. So templates. So read and understand your templates. So templates, and I was looking at the PSR stuff recently, templates are a double-edged sword. Like sometimes they can make us feel a bit laissez-faire about it because we set and forget. So I've put as the last line, don't set and forget. But when we have our templates, we think like, what is the biggest possible picture for this? And then we personalize it down because you know what, it's much faster to delete things out of text than it is to type things in addition. So we have quite an extensive story for some of our auto text that we have in, but then we delete components out and personalize it. So, and that means when you're as a practice nurse or whoever it is that's helping with this, you can use those things as a prompt, but then don't just sit there and not personalize it. The PSR did whack a fair few people for not having personalized, you know what the PSR, the reviews from Medicare. So people not personalizing the GP management plans, just cracking out the same thing for absolutely everybody. That's not meaningful. It's not a meaningful care plan at all. So use auto text though, absolutely, to support compliance. So I would encourage everyone to have a good number of auto text things, because when you're busy talking and Mary Jones is talking about her cat and all the rest is happening and then something's happening, the doctor pops in, there might be, you're trying to do your compliance for your 10997s, but you have forgotten to put these things in. You've forgotten to do your checks, or you think, oh, I must do this. So absolutely use your auto text. So does everyone like auto text? I think it's great. Hopefully you're doing it. But again, don't set and forget. So what technology? So we have what I would consider a sort of 360 approach to education. So I try and educate the patients as much as we educate the team. So, and because we've got an allied health arm to our practice as well, we're sort of doing it in two ways, so a 360 as well. So, but you can use website, you can use your automated recalls, your blogs, your broadcasts, there's all sorts of things, but is there someone responsible for it? Is there a couple of people that are responsible? What messages are you trying to get across and how are you getting them across? My messaging to the patients was absolutely terrible during COVID, except COVID, but now we need to get back in, because I think it's good to educate your patient. What does a care plan mean? You're on a care plan. We have an information sheet at the back of our GP management plan that I do try and get the doctors to hand out, just to say to the patients, you've just received a care plan. What does this mean for you today? So, and what do we expect from you as a recipient of a care plan, and how can you help us to go through the system? Okay, so the entire team should know. So this 360 thing I just talked about. So I would educate the receptionist as much as I would educate the practice nurses and the doctors in exactly the same way as much as I can to keep everyone on the same page. So communicate wins and losses early. So with all pies in the sky, we're never going to get there perfectly, but that doesn't mean, I think Leonie said my motto, I haven't failed, I've just found 10,000 ways that don't work. That is absolutely true. Like, this is what we're doing. It doesn't mean that if you try something and it doesn't work, that doesn't mean you stop. You just wiggle it a little bit and try again. So you might have had a few wins for a small number of people. You might not have had a few wins for 4,000 people, but you're doing steps towards it. Okay, so practice makes perfect. It takes time to develop mutual trust. As I said before, sometimes patients don't want to come into the nurse. Sometimes patients don't want to come in at all. I have found that sore feet are a very good driver of chronic disease management programs, because they really want those podiatry assessments. So anyone with a sore foot, like elderly people with sore feet, they're pretty good at showing up for their GP management plans. A type 2 diabetic, newly diagnosed, that's working? No, not so much. And the MBS is really difficult. It's not really supporting us. It'd be great if we could give them a phone call, or if the practice nurses could do their 10997s over the phone. It'd probably have a lot of meaning, but we have to work within the MBS requirements, unfortunately. And as much as I've tried to talk to Greg, he's not taking my calls. Not Greg anymore. Who is it? Who's the next guy? Mark. Mark's still, he's not taking my calls either. So, okay. So agree on tasks and scope of practice. So who is responsible for these things? What do you do? Does everyone know? Does the left hand know what the right hand's doing, and vice versa? Like, are you talking to each other? So have you had team meetings just about how are we going to tackle this? So I think it's really good to just have open and clear communication about how you're going to tackle it. And as a practice manager and as a practice nurse, I know that not all GPs work the same way. It is impossible. They are very varied beasts. So you can't possibly, are you recording this? Did I just say beasts about GPs? I'm sorry, very varied people. You're not beasts at all. So, but be flexible, because they obviously are having different ways of thinking. They know their patients in and out as well. So when we're starting with trying to get started again, we just generate lists through PenCat. We use PenCat, we pick 10 people, and we give a list of the worst. We sort of go, okay, who is in the most need for this group? Maybe for 707s, it's the most elderly that haven't been in for a long time, and those sorts of things. So we talk about like necessity, and then we distribute the list and say to our doctors, pick 10. Just give me 10 names to work with, and we ask the doctors to give 10 people back. And that's where you start making your pie, putting your bits and pieces together. So, and the GPs will say, there is no way you're getting Alan Smith in because he's going through a really difficult time. So if we were to call Alan Smith and say, like, come in for it, but he's actually going through a really difficult, like his partner's got cancer or someone's just died or something, you just must include, I think it's good practice to include your GPs, because they really do know the stories, even if their billing history is not reflecting their chronic disease management care. Okay. So from a practice management perspective, it would be, I really love that proactive interest in chronic disease management, and in general practice, in across the board. But anyone that has an interest in learning to use data and loving data, yeah, all right by me, come on down. So take initiatives and work to your strengths. So lots and lots of practice nurses, like everyone has great strengths, but some people might be really good at motivational interviewing. Some people might have an interest in diabetes. Some people might love wounds. Like everyone's got different strengths, but work to your strengths. What are your strengths within your team? So learn the software. So many people are a little bit scared of the software, of templates, of changing it, of getting rid of stuff that's archaic. Like, keep it contemporaneous. Like, look at it. Is there templates that have been lurking around since the ARC? Why are they there? Get rid of them. So start thinking about what your infrastructure looks like. Have some goals. When I was starting off with the GP management planning, trying to get that off the ground several years ago, we just had very, very small goals. Like they were the pies, they were the little individual steps. And I was not even on the bottom rung of the ladder. Like, we weren't even close to the ladder. We might have known that the ladder started with L. That's how far away we were from our pie in the sky. So, but we had goals and we communicated them, and gradually, month on month, we could build on that. And then we got to eat the pie. So we still never get there perfectly. Effective communication. I talk a lot. I talk a lot at the practice. So, and I try and talk a lot to my team and see what barriers are coming up, and build on steps within your practice capacity, but do keep your practice capacity in mind, because you can't go nuts. You can't flood the gates with chronic disease management and think that that's going to have no impact on your books. It really will. So, okay. Have I talked for long enough? Any questions from me? Or Leonie can come up here and we can talk together.
So again, I'm sorry if I'm teaching you to suck eggs, but I thought we'd try and do a sample case GP management plan, team care arrangement, and then talk about reviews and 10997. So you probably already all know this, but here we are. And yeah, as Kylie said, every doctor works differently. Every practice has a different approach. So it's important to not personalize it for the patient, but also customize it for the GP and the practice. Now, what did I just missed a very vital slide. Oh yes, top-notch templates, as Kylie was saying, and also deleting things that are not relevant to the patient. So there's some good templates on the Murrumbidgee PHN Health website. So that's a little link to them. They've got lots of templates which you can maybe import into your software and then customize as needed. Okay, now we have Miranda Lau, not Mary Jones, and she's 32, so she's younger. She's single, she's a non-smoker, 2 standard drinks a week, type 1 diabetes and moderate asthma, BMI 26, blood pressure 145/90. She's saturating well, so her asthma's, not out of control. HbA1c may be a little bit high, cholesterol also a little bit high for diabetes. Renal function looking okay, and her medications are Nova Rapid with the pump and the CGM. She's on some Ramipril and some Symbicort, and then I haven't put this down, but maybe she's got some, endometriosis, or maybe she's trying to start a family, so she's got her own personal kind of goals or problems or challenges as well as those numbers. So I've kind of put together an 8-step plan for doing all the item numbers. And so step 1 is consenting for the GP management plan team care arrangement. So you might have been recalled in, but it's actually something the GP has to document in the notes that the patient has consented for the process. And for the reviews, they also have to consent for them. So for most of these kind of item numbers that are care plans to do with a chronic disease management plan, you have to get patient consent documented in the notes. And so then book the appointment and make sure there's adequate time. So I've just kind of did a pie in the sky example of how to have enough adequate time to do a comprehensive GP management plan team care arrangement that could mean something to the patient. So ideally 30 minutes with the nurse, and that's to prepare the document. So to prepare the bare bones document that Kylie was talking about. So collect the history, identify the problems, identify some goals for the problems, and then actions and making arrangements. So the making arrangements within the GP management plan would be potentially with nurse GP follow-up, and then to do it a bit more with a team care arrangement on the side, that would be the external providers. So we'll talk about the external providers in a second. Then 15 minutes with the doctor. So the doctor will review the document, talk through it with the patient, do any referrals that are needed. And then this is the new novel idea, and this doesn't have to happen in this way, but it would make it kind of more comprehensive or meaningful for the patient. Going back to the nurse so that the nurse can translate the beast's language, because doctors do tend to talk fast and talk with technical language, and sometimes patients come out of the appointment with the doctor having absolutely no idea about what happened. So going back to the nurse and the nurse kind of talking through the document again with the patient. Sometimes the patient needs a bit of help making appointments with the allied health providers. So, and also organising for the consent for participation in the team care arrangement to be sent off. So the allied health providers can reply back. So you need to have it documented on your patient notes that the allied health providers have consented to take part in the team care arrangement. So certainly nurses and receptionists can help with that aspect, but I think that kind of the health literacy thing that practice nurses can do in the chronic disease management plan is absolutely invaluable. So looking at the step 2 is generating the problem list, and you could look through the problem list through possibly a prism. So looking at general understanding of the individual problems. So that might be for Miranda, her type 1 diabetes. Does she understand what type 1 diabetes is? Does she have plans for sick days? Does she have plans for when she goes out drinking? So those types of things. And or with her asthma, does she know what her triggers are and how to minimize symptoms? Then looking at her lifestyle. So smoking, nutrition, activity, alcohol, physical activity, sorry. And say with the diabetes, her blood test frequency and her targets, is she meeting them? So that would all be part of her problem list for the type 1 diabetes. Looking at her observations, is her blood pressure in target? Is her cholesterol in target? Then looking at the medication, is she compliant? Is she taking her Ramipril every day? Is she using her Symbicort when she needs to appropriately, and is she aware that she can use it as needed? Then thinking about complications, so the screening like the feet check, the foot check, the eyes, possibly cardiovascular and renal. And then looking at her from a vaccinations and screening perspective, is she up to date with her vaccinations? Are there any things that she also needs? And if you put these on the GP management plan and saying that the vaccinations need to occur and the practice nurse can be the one who administers them, then you can charge your 3 and your 10997 because it's part of the GP management plan. But that has to be documented. Problem, vaccinations up to date, goals, and then who's going to do it? Practice nurse, and there you go, you've got it, and that's legal. So if she was older, mammograms, is she up to date with her CST? And then you've also got to think about her. She's Miranda Lau, she's 32, she wants to have a family and she's got endometriosis. So what about those kind of issues? So putting them on. So Kylie, I think, was talking about this, and she was saying that the more problems, the better. Which kind of is, we always go for parsimony. So try and cover, especially as GPs, one diagnosis for a whole lot of kind of constellation of symptoms. But in this instance, possibly the more the better. And then you can kind of refine and make it workable. So that's looking at the problem list. Okay, so I've talked about that. So then step 3 is goal setting. So for each problem, thinking about a goal. So for example, physical activity, making sure you're walking 30 minutes a day, the blood pressure, getting it under 130 on 80, cholesterol, getting the total cholesterol under 4. So, really clear kind of goals that are achievable. So if someone had a BMI of 45, you would not put a goal as having a BMI of 25. You have to make it something that a patient can engage in, because, giving them unrealistic goals just sets you up for failure and also breaks trust. And it doesn't go, and people don't find the process meaningful. So then the third column of the GP management plan is the required treatments and services and patient actions. So that's when you've got your goals and you've got your clear statement of who is responsible for what. So for example, the blood test for the type 1 diabetes, that would be the GP. The foot check might be the practice nurse or a podiatrist. So that's pretty self-explanatory. Then step 5 is the potential team care arrangement. So to be eligible for a team care arrangement, you have to have the GP plus 2 other health providers external to the practice, although in Kylie's place, it could be next door to the practice. So it can't be 2 GPs in the practice and a practice nurse. It has to be a GP plus 2 other healthcare providers. So that would either be, say, for example, a physio and a dietitian, or it could be an OT and a medical specialist, and that would qualify you for a team care arrangement. So when you're doing the team care arrangement, you're going to synthesize the goals and the actions and the problem lists and create a plan that involves the external providers. And then you're going to send it off to the external providers and ask them to return to you that they consent to be part of the team care arrangement. And so then step 6, so they've been with the practice nurse all that time. Now it's time to go into the doctor. And the doctor will kind of order the tests that might be needed, do the referrals to the allied health specialists and the specialists. And then that's our new novel idea of going back to see the nurse afterwards to translate everything that's just happened. So in terms of that, you could potentially do it another 15 minutes back with the nurse on the same day, or you could do it as a 10-997 in a month. Get the patient back in a month to see the nurse and just to touch base about, did you understand what happened? How's it going? And also to arrange any follow-ups. So like to put in a recall for a 732. So the 732 can be done 3 to 6 months after the 721, 723, and any further 732s. So as you probably all know, after you've done your GP management plan, team care arrangement, you can do the review 3 to 6 months later, and you can do reviews every 3 months. The GP management plan is valid for 24 months. So they can have reviews every 3 months until that 24 months is up. And to do the review, you have to do the review of the TCA. So all these kind of services are bulk billed. But if you were going to do a GP management plan, team care arrangement review, that could potentially be about $130 that is bulk billed for that appointment. But you have to have, for the team care review, you do have to have further updates from the allied health person. So that second letter saying how are things going, how's the progress, and that has to happen at each team care review. So you might be getting 3 or 4 letters from the podiatrist for each team care, each time you have a team care reviews. Okay, so I've talked a bit about the team care and GP management plan reviews, and here's a nice little template that's got a 6-month review, a 12-month review, an 18-month review, and the problems, the goals, the treatments, and the arrangements. So I thought that was a nice template. And last of all, the 10997 that Kylie talked about, and that can be claimed 5 times a year. And it can be claimed for all kinds of things. So if you've got in your GP management plan vaccinations, then it could be for that. It can be for education. So does patient understand condition? So the nurse can educate that. And that's kind of like very meaningful for the patient to do. And I think it's really appreciated by the patients. And look, you know, the beasts are sometimes unapproachable, but the practice nurses, all the practice nurses I've worked with have been fantastic. There's Louise, there's Rachel. So yep, big kind of things. And all the nurses love the practice nurse. I mean, all the patients love the practice nurses. And I'm sure that they sometimes go up to them and say, what was she saying? So yeah. Okay, so that's my second bit of the talk. Did you want to summarize now and then we'll do questions? Yep.
Care plans built under the usual GP that has provided the care for the last 12 months, or will be providing the care for the next 12 months, and the care plan was about osteoporosis, and the patient had a Prolia shot in between, which is described by another GP, was prescribed by another GP and administered by a practice nurse. Can the 1097 be billed under the document that prescribed Prolia, or does it have to be billed under the GP that billed 723 or 721 and 723?
Okay, so I think this is, so for our practice, it depends on what our practice, the practice retains the 10997. So we don't pass that on to the doctor. So because we employ the practice nurse and it's in their contract that is a retained billing. So from our point of view, it kind of really doesn't matter. You could bill it under the doctor. I wouldn't be billing under a doctor that wasn't in the country, but I would be billing under a doctor that was in the practice. So, but we retain those billings anyway. So when I do the doctor's pays, I take that off them, and that's part of their contract because we use that. They're not getting a percentage of the work that we're paying the nurses to do, but that is completely in your contracts. So it is depending on how your practice is set up for that. And I will just say on that 10997 and billing for vaccinations and things, don't just assume you can just shove a vaccine in an arm and bill a 10997 and a 3. So you do have to document, use your auto text to document your compliance and how that is working towards the care plan of the patient. So I like to think as the the GP management plan as a roadmap and almost as a work order or a script in a lot of ways, because the GP is actually defining the scope of practice in a lot of ways for who they want what to do when and why. So, and in that, like you would ask for any flu vaccinations or something, if you need a script for that, then essentially you can think of the GP management plan like a roadmap for those patients. So, and it's defining the scope of practice. So, but in that, documentation is really important. Don't go away from here and just think you can look back on every flu vaccination you've ever done of a person that's got a GP management plan and think you can retrospectively whack a 10997 onto it. You can't. It's all about your documentation and MBS requirements. So I just want to make that quite clear that if you're co-billing those things, you need to be clear that you're meeting the descriptor all the time with both those requirements. Okay, bringing it together. So chronic disease management can have a direct path to better patient outcomes. I really think that that's what our pie in the sky is we're really looking for better patient outcomes for these patients. And part of that, as you all know, like general practice is getting very expensive to run and out-of-pocket costs. There's a lot of bulk billing that's going out the window for patients. But chronic disease management is a way that a lot of practices, I'm not saying all practices, because some practices might privately bill for their chronic disease management, and that's perfectly valid. But it is an opportunity to be getting revenue at an increased rebate for your patients, but your patients to be able to come to the practice, and most often they will get bulk billed. And by having that relationship and bringing the patient back regularly, having them form a relationship, not just with the doctor, but with the nurses and the practice team, that is enabling you to be able to better help them navigate the health system as they age. So, and I always say to like I say this to new patients, don't just ring us when you're sick and want to come as a new patient. Come and tell us your story when you're well. So then when we are sick or as these chronic diseases develop, we can help be your partner. Our motto is working together for better health. That's our practice motto. So, and that's what care planning and chronic disease management is doing. It's helping us to become partners in health, and the practice nurse plays an absolutely vital role in that. So chronic disease management can have an effective impact on practice income without, I've talked about this, without increasing the out-of-pocket cost to patients. So, and I really think that learning to love and work out what your pie looks like for chronic disease management helps practice nurses to feel really integrated into the team. So I think because you do have a really big scope, you can really work to the top of your scope of practice. You can really work with your strengths and your passions, and you know that you're really contributing. It's just getting to know what your pie looks like and how that works within your practice, and having it really clearly communicated so you can really run with these things. I've talked about that nurses often feel isolated. It is sometimes practices like mine, I just simply don't have the space for 2 or 3 practice nurses all to be working at once. We just haven't got that space. So often the practice nurse is working on their own. And but working together, even if you are a solo nurse working in a general practice, then that's when you need to form a team with other people within your thing. And I always tell my receptionists, you are healthcare providers as well. Like you are in the health game too. You might be called just a receptionist or just a GP, but they are really healthcare professionals as well. And so they can have just as much of an interest in chronic disease management as anyone, and really start feeling that they've got some work. So you could, if you're a solo nurse, buddy up with someone like me, or someone that's like me in your practice that has an interest in this, and you might be able to kick some real goals with that. And systems, scope and goals really do help. Like we just really, you need to start thinking about what are the barriers in your practice and how can you make baby steps towards overcoming those. And I will finish with my motto. It is a very, very true one. I read it on the gym wall once when I was trying to lift something very heavy and painful. So, and it really, really resonated with me. I've not failed. I've just found 10,000 ways that didn't work. So, and I think that's our thinking, like even those small attempts that we're making at improving our practice, whichever you're doing, whichever quality improvement task you're doing, chronic disease management, all the rest of it, those baby steps and even the failures, they're all fine. Just keep trying. So thank you. I don't think I've got anything else to say. Thank you to Leonie.